Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Today's episode is going to be a rebroadcast of episodes 55 and 56, where we interviewed Dr. Nicole Harkin, cardiologist. So why the rebroadcast? Because cardiovascular disease is so prevalent across the whole world, and it's actually the number one leading cause of death in all-cause mortality. So because of that, whether you're new here or whether you've been with us at Medicine Redefined, we think it's so important to keep cardiology and the technicalities about it so fresh in your mind. It's important to think, on a daily basis, on a weekly basis, what are those things that we can do to ensure good heart health? And so in this episode, we delve into cholesterol and lipids, what an APO-B might mean, what's an Lp(a). There's so much research coming out. So we want you guys to be advocates for yourself when you go into the doctor's office so that you can be confident when you tell your doctor what type of tests you want so that you can really look into certain risk factors. And of course, we delve into those lifestyle interventions to keep us healthy: exercise, diet, stress management. So yes, this is a 2-hour episode. We are combining our two previous ones. But again, it is technical, and I think it serves well to re-listen to this if you already have, because if we can do one thing to really become healthy, it is to look at our heart and to reduce that risk. All right, enjoy the episode. Dr. Nicole Harkin, thanks so much for coming on to this podcast.
You're so welcome. Thanks for inviting me. I'm excited.
Absolutely. So, Altamash and I have had Medicine Redefined now for about a year. And for a year now, we've been saying we need to talk about cardiology, right? The number one leading risk factor and death, when we talk about being healthy and lifespan, longevity. So finally, you've made our wish come true. So again, thanks. But I really want to delve into your journey, right? I think there's a lot of pre-meds and medical students who think about going into cardiology, when they think about medicine. What made you choose cardiology? Take us through kind of, back then, a little bit about your journey.
Yeah, absolutely. So I started actually thinking, I was kind of a late bloomer into cardiology. I feel like a lot of cardiologists you talk to, they've known they wanted to be a cardiologist for a really long time. I sort of came into it later in my medicine training. So early on, I was actually, and remain interested in, but very, very interested in global health and international health, and did a lot of work abroad. And so at that point, I really thought I was going to be an infectious disease doctor, which kind of is a natural complement to that experience. And so throughout medical school, that's really what I thought I was going to do, and thought I was kind of going to do a public health sort of dual degree and things like that. And then eventually started kind of getting interested in cardiology. I think a lot of that started actually when I was in Africa, and obviously a lot of my work there was infectious disease related as well, AIDS and TB and things like that, but started to actually really truly understand the global impact that cardiovascular disease has. So it is the number one killer worldwide in every country. And so just seeing just rip-roaring uncontrolled hypertension, lots of premature heart disease and things like that. And started and that's kind of, I think, when the first light bulb went off, oh yeah, there's a lot else out there. And then, the heart's cool too. So then I started getting really, it's the physiology of how the heart works and all the things that happen is really just intellectually very interesting as well. So just really started kind of thinking about that. And then I went to Columbia for internal medicine residency, and it's hard not to like cardiology there. The cardiology department is huge there, very influential, did a whole rotation there, and just really kind of fell in love. And so ultimately decided to sort of marry my two interests in in kind of preventive health and cardiology, and really kind of become a preventive cardiologist. So that's when I, in fellowship at NYU, they have a huge preventive cardiology group there. So worked with them a lot, which was a great experience, and I can talk about that more. And then eventually decided to get boarded in clinical lipidology, and that's sort of where all of that experience kind of evolved for me.
I love that. I do agree. The heart is very, very cool. And I always tell my colleagues that, in another life, if I didn't go down the sports medicine pathway, which is my calling, I certainly would have done cardiology. And yeah, you've had a long journey, right? I mean, so 3 years of internal medicine, 3 years of cardiology, and lipidology. Is that more fellowship time, or do you just sit for boards on that? How does that work?
Yeah, so it's just really independent study, and then you sit for additional boards. So the National Lipid Association has kind of some self-study stuff that you can go through and go to some of their conferences. They've got like a crash course for people that are looking to get into lipids, and you can attend the conference and then take it. And was definitely mentored by many at NYU. I actually was the first general cardiology at NYU to take those boards and pass them. So that was kind of exciting.
That's awesome. And I agree, as you alluded to, that cardiovascular disease is the number one killer globally, right? Particularly in the developed world. I mean, that's certainly the case. And we've talked about metabolic ill health several times on this episode, right? And I think this stat that I've thrown out several times, I wonder if 43% obesity in this country, in the United States, right? And the expectation is that in another 8 years, that's going to be 50%. And I shouldn't say this, but I think largely lack of education isn't a problem, right? We spend a lot of time talking about fruits and vegetables on this, and we can do all these things, yet people continue to get, unhealthier and healthier. Recently, a study that I can't remember, but I think it was 2018, was published that 88% of Americans had at least one marker for metabolic syndrome, right? I think that the most recent data, when you look at weight gain during the COVID-19 pandemic over the last 2 years, in just not only the adult population, but in the pediatric population, I think there was some stat that between the millennials, which I think all of us are millennials probably, it's like 25 to 40 something pounds. So, I say all that to say that it doesn't seem to be getting better despite all the information that's out there. And one of the things that, taking all those things into account, that's important for us to do is spend a lot more time talking about risk stratification and diagnostics and things, that how can we identify these things earlier on, which is what you're passionate about, right? Preventative cardiology, rather than later on sick care, And so what are some ways that you tend to detect disease much earlier on? Maybe not in people in their 50s and 60s when people really start worrying about their heart health, but 20s and 30s.
Yeah. So, we have a pretty robust understanding of the major risk factors for cardiovascular disease, right? And I think in general, we don't do a great job of employing those tools and using them on a regular basis. So I don't know what the stats are for how many millennials have a primary care doctor or have ever seen a primary care doctor, but I'm sure it's like pretty low. So unfortunately, what happens is a lot of people don't get screened early on and don't identify, cholesterol, high blood pressure, all of these things that we should be screening for on a regular basis, right? And so just kind of even taking some of the traditional risk factors that we know about, high blood pressure, BMI, smoking, all the usual suspects. I think that those don't get identified early enough on. And that's just kind of some of the stuff that we all know, right? That's even before you get to some of the more advanced stuff, which I'm sure we'll talk about in terms of really fine tuning risk and looking at different advanced cholesterol markers and in early signs of insulin resistance and all of this other stuff that we should arguably be doing as well.
Dr. Harkin, at what age would you say you would typically look at risk factors then? I would assume when you look at the ASCVD, it's like 40 to 79, right? I think for optimal results. But now when we see obesity rates climbing so high, Are we looking even younger, less than 20 maybe, to kind of look at these lipid panels, for instance?
Yeah, no, for sure. So pediatricians are supposed to draw cholesterol panels in all children at some point, and they're historically it was because we were screening for genetic dyslipidemias, right? So,
Okay. Yeah.
so kids as early as 8 can go on statins if they have evidence of a very elevated LDL cholesterol, which is diagnostic of familial hyperlipidemia. So traditionally, that's what we were screening for. But if you talk to pediatricians now, they're actually screening them early for, and they check blood pressure and things like that, but they are seeing blood pressure, cholesterol, BMI, as you mentioned, in adolescents. And so now we're not only seeing evidence of genetic dyslipidemias and issues of true genetics, but really truly lifestyle related elevated risk of cardiovascular disease. And that's truly scary because in the prevention world, we talk a lot about primordial prevention, which is like really starting young. Well, what's primordial prevention anymore? Is it, in utero? So I think that the ball feels like it keeps moving in terms of, okay, in the cardiovascular world, we have lots of conversation about this blurred line now between primary and secondary prevention based on some of diagnostics and things like that we can do now. But I even feel like we're blurring the lines completely and totally. And we know from studies decades and decades ago that young men and women who died of other causes, if you look at, so I don't know if you guys are aware of some of these studies, but from decades and decades ago, I think it was even the Vietnam War, they would do autopsy studies and look at men and women who had died in war. And there was already signs of atherosclerosis. These young people, and this was then. I'm sure that is even worse today.
Absolutely. I mean, I think in all of our pathology classes, we learn that this, the atherogenic process begins in your teenage years, right? And it's kind of exactly what you're describing here. So let's dive a little bit deeper into, we've talked about the lipid panel. You've alluded to LDL and how that can be diagnostic when it's extremely high in the pediatric population. For those who might not know, what are the different things that would pop up on a lipid panel, like total cholesterol, and then from your cardiologist's eye, what stands out to you most? What are you looking for? What do you make of the lipid panel?
Yeah. So if you go to your doctor, the traditional lipid panel that you'll get is something that's comprised of the total cholesterol, which is all the cholesterol that we can measure that are contained within the lipoprotein particles in our bloodstream. And then that gets broken down into HDL cholesterol, LDL cholesterol, which is calculated, and triglycerides. So LDL cholesterol is what I mentioned. It's calculated based on the other parameters, and that is a measurement of the amount of cholesterol contained within your LDL particles. And that's important and does not get discussed enough. And we'll get into why that's important. But it is it is a lot of people think that that's kind of the end all be all number. And first of all, it's calculated. And second of all, it's the cholesterol contained in the particles themselves. And so the reason it is important to look at your LDL cholesterol is that is where most of our data is at this point in terms of what does an elevated LDL cholesterol mean? And we have tons of data, Mendelian randomization, epidemiologic, RCTs, all of this that lines up that shows that elevated as your LDL cholesterol goes up, your risk of cardiovascular disease and death from cardiovascular disease goes up. And as we lower it, your risk goes down as well. And so that's where a lot of our data is. And it's a very strong correlation and a very robust correlation. And so much of the drugs that we use are the kind of the first line offense against cardiovascular disease is working on lowering that LDL cholesterol. And so that is our primary target. And will probably remain so for some time in terms of trying to get that to a lower level to prevent cardiovascular disease because it is causative. It is necessary to develop cardiovascular disease. And maybe it's worth briefly going into the pathophysiology of what is atherosclerosis. I don't know if that's worth it or not. Yes, no?
Yeah,
Yes,
absolutely.
please.
Yeah.
So super high level of it is, as I mentioned, these lipoproteins, predominantly your LDL particles that contain cholesterol that are thought to be atherogenic. And there's also VLDL and other types of lipoproteins, and we can get into those at some point. But those are the primary, in most individuals, the largest population of atherogenic particles are those LDL. And so what happens when that concentration of APO-B containing lipoproteins is elevated, that concentration is higher in the plasma and then diffuses across the endothelium into the arterial wall. And through complex things that occur, the LDL cholesterol gets oxidized. That's highly pro-inflammatory, and you get the beginning stages of an atheroma. And so, and then as those sort of grow, then you can get different complications, either obstructive coronary disease, which is when that plaque becomes large enough that it's obstructing the blood flow to the heart, and that's when people get angina and chest pain, or you can also get a myocardial infarction, which is when that atheroma actually bursts. Actually, one of my mentors always compared it to a pimple popping, which I think is absolutely disgusting, but very you can just visualize exactly what's happening. And then that sets off the inflammatory cascade and coagulation cascade, and you get a clot that forms kind of on that, and that's a myocardial infarction. And so, those are kind of what and importantly with that, studies have shown, and it's somewhat controversial, but studies have definitely shown that it's not always the biggest. When we're looking at caths and things like that, get nervous about the 80 and the 90% lesions, but sometimes it's those 20 and 30% that can cause the MI. So that's what we're trying to prevent. And endothelial dysfunction is important and allows those atherogenic particles to get into the endothelium more easily. So smoking, obesity, all that kind of stuff can, hypertension, make our blood vessels more prone to allowing that cholesterol to deposit. But you have to have cholesterol in order to make a plaque, right? And so while it's important, obviously, to control these other risk factors, if we really control and lower that concentration of LDL particles in the bloodstream, we can really prevent the deposition and then therefore coronary artery disease.
I love that you said that. And it's funny because you started off with this is going to be a high level discussion, which it is. And I think that for you understand that. And I think for most people, when they look at a lipid panel, they kind of just characterize good versus bad cholesterol, right? Like, oh, HDL high, good, LDL high, bad. And it's much more complex than that, as you just briefly touched on. You mentioned LDL particle number and particle size a couple of times, or you alluded to at least particle size. And I want to go down this rabbit hole a little bit further, because there are some people who will talk about how it's critical for us to evaluate particle number and particle size, because that's really what matters, right? And you kind of mentioned that LDL is calculated, the LDL-C that's typically shown on a lipid panel. And so say a little bit more about why it's valuable, if at all, in your experience, to check, an LDL particle number and size, and what that means, in terms of small, medium, and large LDLs.
Yeah, so this is somewhat controversial, but and it remains that LDL cholesterol is, for many, a very good indicator of cardiovascular risk associated with your cholesterol. That said, it misses many people, and in particular, it tends to miss, and I have seen this time and time again, in individuals in whom there is the risk factors of metabolic syndrome, obesity, et cetera. And as you mentioned, now 42 to 43% of our population fits that criteria, at least has obesity and is likely also metabolically has some metabolic issues associated with it. And so in that population, the association, the discordance between your LDL cholesterol and the number of particles you have is higher. And so you will underestimate their risk associated with LDL cholesterol if you're just looking at that LDL cholesterol. And so what I mean by that is that as I said, for most people, when you measure the cholesterol that's in these lipoproteins, you're getting a good sense of about how many they have. Now, in individuals who have very high triglycerides and metabolic syndrome, you tend to get several. So instead of having, say, 5 large fluffy LDL cholesterols, you'll have 10 small dense LDL particles. And what we've shown in those individuals is that those who have this LDL discordance, meaning they'll have higher APO-B or LDL particle, however you kind of want to measure it, then their LDL cholesterol would lead you to believe. So you'll get their LDL cholesterol back, their standard lipid panel back. Oh, your LDL cholesterol is, 95 or 100 and not so bad, right? But then you draw an ApoB or an LDL particle on them and their risk associated with that is much higher than you would anticipate based on their LDL cholesterol number. That's discordance. And their risk is, studies have shown that their risk of cardiovascular disease in those individuals is much more closely tied to that elevated ApoB or LDL particle. And so that's where measuring those kinds of numbers can be really important and dramatically impact that individual's risk modification strategy.
Gotcha. Now, in a standard lipid panel, we're just getting the concentration number, correct? We're not getting the particle number.
Yeah.
For LDL.
So you're just getting the LDL cholesterol is 100 milligrams per deciliter, correct?
Okay. So then in order to obtain the particle number, is that you would have to do a separate test for that? Or
yeah, so you can order ApoB separately, and many people are doing that. And in fact, if you look at the European guidelines, they really are taking that into account and recommending that it's considered a secondary marker, but the European guidelines do kind of mention ApoB as something to follow as well, and kind of do outline some of what we just discussed. So you can order that separately. If some people also do what's called like an advanced lipid panel, and you can get it through Quest and LabCorp and all your usual suspects, and that will give you sort of the LDL particle number, and then give you the sizes and things like that.
This might not be a great question to ask, but when you're looking at the advanced lipid panel, you're looking at LDL particle number. It shows LDL particle number. It'll show small, medium, large. Am I missing anything? What else will it show?
Yeah, and then it does look at like the HDL sizes and things like that. But if you use that to treat, do you ever use the particle number to treat? Yes.
Okay. If you're using that, are you more concerned with the small LDL or then the number of small LDL, or are you looking at the total amount of particle, like the LDL particle number?
So I think the data is stronger when looking at counting numbers of atherogenic particles. So whether you're using ApoB, which is capturing kind of all of the atherogenic particles, or LDL particles, that's kind of looking at numbers. That to me has the better data behind it in terms of more closely estimating cardiovascular risk. And so I tend to pay attention to those more. Typically, though, in individuals that you see this discordance phenomenon in which case measuring those kinds of things is more important, they will have a predominant small LDL pattern. So you're kind of taking it in, it goes hand in hand, if you will.
I got you.
So you're sort of taking it into account anyway.
You mentioned at the outset that it remains controversial, and you have eloquently described that in cases of discordance, which tends to be high with, again, metabolic syndrome. And I think for those who don't know metabolic syndrome, so the 5 things that triglycerides about 150. Oh my God, I'm actually forgetting all. Somebody, you guys help me out. What are the other 4? I know your
waist circumference.
Waist circumference is one. Your blood pressure, right? Elevated blood pressure. A1C of 6. How high is the A1C?
It's just glucose still.
Just glucose?
Yeah.
And what's the last one?
Over 100, and then HDL. Low HDL.
HDL, right?
Yeah.
Low HDL, lower than 40.
Less
Is that what
40.
it is?
40 or 50, depending on your male.
40. Okay. So, and we mentioned again, recent study showing that 88%, we talked about the obesity numbers. Why not use LDL, right? If we know that if we have compelling enough data to support that when you have discordance, and again, I think we've all made the argument that metabolic syndrome is on the rise. Why not? Why is it controversial?
I'm not part of the guidelines committee. I think that, so what I would say is that, I think that we do have a robust data set looking at LDL cholesterol. It's what all of our clinical trials, for the most part, when you look at, using statins, PCSK9 inhibitors, all these drugs, the targets, the goals, the numbers are all based on LDL cholesterol. And so some of that, I think, to be fair, is because that is sort of what our data is on in terms of targets and things like that. I think also what's brought up is, cost. Although APO-B is not very expensive at all to add on. So that is a little interesting to me. What I also hear is sort of making it more complicated for the average busy clinician to sort of sort through. We're all so, you see an LDL cholesterol number, right? And you kind of intuitively have a sense of, okay, that's high, low, or not. I don't think the average clinician, so we'd have to really switch over our thinking if we were to then focus on particles or ApoB or something like that. So, I think that these things take time to shift over in terms of kind of all of that stuff. I think that the European guidelines, I think, are a little bit more reflective of what a lot of us are doing, who are really, seeing individuals who, we really want to focus on optimizing heart health and not just like, oh yeah, oops, you had a heart attack. Let's optimize it early.
Preventing,
that heart attack, right? So, in terms of measuring Lp(a), they recommend checking that once in everyone, which I think is totally appropriate. So, I think things will evolve over time, hopefully.
Yeah, change takes time.
Yeah, it takes time.
Absolutely. No, I do like that. And what's interesting, actually, a recent podcast that Alan Snyderman on Peter Attia's podcast just a couple of weeks ago, we'll link to that, and they go into depth and a lot of things that you just mentioned right there in terms of, at the individual level, why the guidelines are the way that they are. Of course, there's a lot of narrative in that rather than evidence. But if Alan Snyderman is, you probably, he writes a lot about particularly ApoB, and he's not necessarily on the guidelines as well, but he's got a lot of great work on this. So we'll link to that. But let's talk a little bit more about ApoB, right? I think that there is probably more of a consensus. You already mentioned that the European guidelines, I think you're alluding to the ones in 2019.
Yeah.
Is 2018 or 2019? Yeah. That are already using that and suggesting that this is maybe a good marker for, cardiovascular health. Some people, again, will argue that, hey, non-HDL cholesterol, which I think a standard lipid panel, it tracks it close enough. And I've had a conversation with one or two lipidologists who have made that argument. However, my just brief understanding of literature, the issues that you mentioned in terms of discordance for metabolic syndrome tend to be the same when it comes to non-HDL, right? Particularly when triglycerides are high, which we'll talk about in a future episodes, how it can be easily manipulated with diet. Non-HDL does not track well with ApoB. I'm curious to get your thoughts on that, and when it would be good to use that versus just get ApoB, that kind of stuff.
Yeah, so I think non-HDL cholesterol is so. Before LDL particle and ApoB became a little bit more mainstream, that was definitely what I was taught to use, even more so above and beyond the LDL cholesterol. So I think that a lot of people call it the poor man's ApoB because it is in that panel already. And I think that it can be really useful if you don't readily have one of those other markers available to you. That said, when you look, most of the studies have shown that that ApoB has the strongest association in terms of cardiovascular risk, and it counts for all of those other things, right? So sure, LDL cholesterol is typically associated, maybe non-HDL is like a little bit better, but really ApoB has kind of takes into account all of these things and is probably the most accurate thing to measure in terms of assessing cardiovascular risk. Does that make sense?
Yeah, absolutely. And, again, just to kind of drive home that point, I would argue that APO-B, as you mentioned, it's going to be the lipoprotein that's going to be in all of these markers. You talked about IDL, VLDL. And although LDL are primarily the ones, as you highlighted, that are going to be responsible for, atherogenesis and that process throughout the entire body, there is evidence to support that VLDL does that. In preparation for this discussion right here, I was just kind of doing some light reading on cardiology journals, if you will.
Casual light reading in lipidology. I don't think there is any such thing.
Yeah, there. And as a
lipidologist, I'm like, oh.
It can be really fun. Like you said, you would really have to have a passion for it. And I saved this. Didn't really go through this, but this article in 2020, and it's actually in JACC, was published talking about how VLDL cholesterol accounts for 1/2 of risk of MI associated with ApoB containing lipoproteins, right? And so my thought would be, why not? Rather than use the poor man's thing, why not just get the marker that's going to be, and you're going to capture what you're going to see on IDLs, VLDL. I think in a world where we're getting closer and closer to taking care of our patients at an individual level, like this word precision medicine, it gets used a lot. And why not check that? And so I have difficulty again, this is a non-cardiology bias. This is just a person who wants to optimize health rather than just treat people who are sick. But I'm from your sense, who has the wisdom, who've been in the conversation with lots of cardiologists, you've trained in some prestigious institutions. What's the argument on the other side about not doing it, at least in this country, in our healthcare system?
I think it is continuing. It's an evolving conversation, right? I think that it's taken, as with all of scientific endeavors, it takes time before something becomes more mainstream. It just does. And so, I don't, there isn't great arguments against it other than the ones that I mentioned, right? So people argue against cost, people argue against, really having to re-educate the general busy clinician as to what to look for. And so, do we overly complicate it? That sort of thing. And there are some that say that there's not, given our robust data with LDL cholesterol, there's not enough evidence yet that we need to necessarily pay attention to ApoB. I personally find that we have enough, and I think that I've seen it in enough, anecdotally, and enough of my patients. I have seen this major discordance, and where I get lots of patients who've just had a basic lipid panel. Oh, my doc's told me my cholesterol is fine. My cholesterol is fine. And then either they have an event, and so then they come to see me and they're like, what's going on? What happened? Or hopefully not, they didn't have an event, but they eventually found me, and we look at either LDL particle or ApoB, and it's definitely much higher than you would predict from their LDL cholesterol. And so, I think that given we have so many medications and lifestyle changes at our disposal to really lower risk due to cholesterol, it's in my mind, it's a missed opportunity.
I love that. And I think as much as both Darsh and I are passionate about, optimizing health and practicing precision medicine, I'm I think just as passionate about practicing cost efficient medicine. I think there's something to be said about that. I think in that episode that I referenced with Alan Snyderman, they actually discussed this issue. I'm not sure if you had a chance to listen to it, but Alan Snyderman practices in Canada, so they have different, obviously, but at least Peter T had mentioned that he called the lab, and I think it was $2.50 for ApoB, right? Something like that, right? I haven't verified this personally with Quest or LabCorp or whatever, but if it is, that doesn't really, so I don't.
In a world in which every patient in the hospital gets the regular set every morning, and you're like, yeah, I think probably you can handle the $2.50.
So coming back to your practice, right? If a new patient comes in, maybe in their 20s, some individual, he's active, he's healthy, he, whoever, and they want to, optimize their chances of, living a healthy life and a longer life. What are some of the basic things that you're going to look at? Of course, I know you've talked about this. Family history is, super, super important, that kind of stuff. But aside from that, when you're looking at objective things, what kind of lab values really stand out in that initial consultation that you'll order?
Yeah. So there's definitely not, as you mentioned, I try to practice a both evidence-based and kind of precision type medicines. There's certainly not kind of a one-size-fits-all approach, but certainly I do tend to look at both advanced cholesterol panels, so many of which we've discussed already, the benefits of either an LDL particle number or an APO-B. I also almost always measure an Lp(a) if someone hasn't had that measured already. And we haven't touched on that yet at all, but
Let's do that.
You want to do that now?
Let's get into it.
Yeah.
A really important marker. So Lp(a), lipoprotein (a), is another. So as we've mentioned, LDL particles are kind of, for the average person, the primary atherogenic lipoprotein that's circulating in our bloodstream. For potentially as much as 1 in 5 of us, lipoprotein (a) may also be significantly elevated and a major risk factor as well. And so lipoprotein (a), it's basically like an LDL particle, except it has the little a moiety on it, which incidentally is very similar to plasminogen. And so that's thought to be part of why it is has increased risk of thrombosis. So what we have found is that individuals who have elevated Lp(a) certainly have an increased risk of cardiovascular disease, and so it's Lp(a) is thought to be atherogenic, just like LDL cholesterol, and it is unfortunately genetically mediated, in that it's very much, and this is why the European guidelines recommend checking it once, and at least once in everybody's lifetime, because it is it's genetically mediated. So if you have it, you have it, and it doesn't appreciably change that much over someone's lifespan. In women, it does go up a little bit post-menopause, but that's really about it. It is influenced somewhat by diet, but not nearly as much as, say, LDL cholesterol. And so in addition to being associated with cardiovascular disease, atherosclerosis specifically, it's actually also, as I mentioned, associated with an increased risk of DVT-PE. And then it's also associated with an increased risk of aortic stenosis. And so those are kind of the things that we need to just be mindful of in individuals who have an elevated Lp(a). And I have plenty of patients who have had cardiac events, and that's really their only identifiable risk factor is this Lp(a). And so at the moment, we don't have any therapies for it, really. So statins, so as I mentioned, diet does not tend to change it dramatically. Statins, if anything, might increase it. And so really what we're left with is kind of niacin and PCSK9 inhibitors. So niacin can definitely lower it. It's pretty controversial to use it. I typically don't, but some of my patients have been on it for some time and are pretty want to stick with it. We don't have any outcomes data. So while we know that increased Lp(a) is associated with cardiovascular disease and causative, we actually don't have any data yet that lowering it will definitely reduce risk. So PCSK9 inhibitors are our best bet. They can lower Lp(a) by 20 to 30%, depending. It depends. And there's some signal that in individuals who had an elevated Lp(a), when they're on PCSK9 inhibitors, they had lower risk of events above and beyond what would be expected just by their LDL lowering. So when I have patients who meet criteria for PCSK9 inhibitors and have elevated Lp(a), I definitely encourage them to use them.
So, for people who are like kind of anti-medication, right, and we hear about this population all the time, if they get their Lp(a) measured, right, and it's high, are we measuring it just to see what type of medication and therapy we can use towards it? Because you said it's not going to change much, really not much effect from diet. So there's not much lifestyle modification that can lower the Lp(a). So are we really just drawing it to see what we can give?
So currently, how I use it most typically in my practice is really to be able to guide treatment decisions about other risk factors. So it is, and in our guidelines, it is recognized as a risk modifying factor. So certainly in individuals who have an increased Lp(a), my threshold for where I'm okay with their LDL cholesterol, for instance, or particle APO-B is really low, right? So I push those people down as low as I can. I really make sure that we're optimizing everything else that we possibly can because of what I've seen Lp(a) do.
Yeah, I think it was maybe a different podcast. I actually might have heard you say that diet, or at least maybe it was diet or a plant-based diet, tends to increase Lp(a).
It has. There was one small study where it actually increased. It's strange. I mean, some of the, like I said, but it's not. I mean, it definitely that goes along with the statin data, which also increased. So paradoxically, some of the things that we have that we know that can lower LDL cholesterol either don't do anything to Lp(a) or make it like a little bit worse.
So I don't want to go too far down this pathway in terms of treatment, but if you did get the Lp(a) and it was elevated, and now you're going to be, taking that information, you'll be a bit more aggressive in everything else that you do in terms of prevention, primary prevention, but also keeping in the back of your mind with the statin data. Would you still put somebody on a statin from a protective standpoint because that's strong enough evidence?
Yeah. So I definitely, and even though I know that it's possible Lp(a) may increase a little bit with statins, if their LDL is not where it needs to be with diet alone, I have a very low threshold to add it.
Do you find when you're having this discussion with your colleagues, possibly working in academic centers, that they are quicker to, or they put less of a fight to order this test? What's your sense on that?
I do think that Lp(a) is definitely way more recognized at this point. Unfortunately, I still think people are thinking about it too late. So again, but this is true of a lot of medicine, and exactly I think what you guys discuss a lot on this podcast is that, I hear my colleagues thinking of ordering it in an individual who's, 42 and comes in with their first MI and their LDL cholesterol is not so bad, right? Oh, maybe this is Lp(a). Which is why I think the European guidelines that say we should all just get it checked at whatever age is a great idea, because I'd much rather pick it up before that 42-year-old had the heart attack, because and again, we don't yet have great therapeutics, so I'm not saying we 100% could, but I'd at least like to give it a shot.
I find that really interesting, because one of the things that we all learn, most of us, I should say, learn in medical school and during our training, is that you don't order a test unless you're going to know what to do with it, right? Unless it serves a purpose, right? We don't want to do unnecessary testing, again, for the cost of the healthcare system, whatnot. And kind of what we talked about, niacin is one treatment. I think that's very, very cheap. PCSK9s can be ridiculously expensive when you're paying out of pocket, and they're not going to be covered in a 20-year-old for primary prevention. There are some things out there. ASOs, I think, is antisense oligonucleotides, right? I mean, but that's like super, super early and for ridiculously high risk patients. And somebody who's had already the 42-year-old who's had an MI and a couple of stents that you're talking about. But you mentioned that some docs might be quicker to order this test, but at the same time, we don't have much that we can do. Yet people will not order APO-B or LDL particle when we have therapies that we can, target them and kind of modify them, if you will. I find that interesting.
I can't say that I am able to explain that phenomenon.
Yeah, that's so. Do you want to say something about the ASOs, just so people have a sense of what that is and what your experience is, in terms of where we are with the current state of the evidence with that?
So in terms of, there is one medication that's in kind of late stage clinical trials that's looking at lowering Lp(a) in individuals who have established cardiovascular disease and are considered high risk. And so I think we're at least a couple years out from that clinical data, though, was the last time I looked. I think it's like 2 years away or so. But I definitely, am letting my patients who meet that criteria know, because and again, to that point of what you've said, about feeling like you're drawing something that you can't do much about. I think that's important that in patients who do get this drawn and it is elevated, that you are able to educate and counsel them as to what the implications are of this and what they can do about it so that they're not completely, totally defeated. So yes, I let them know that there are some medications on the horizon, but I think just being very aware and not just ordering it to order it and then not know what to do about it. Because I definitely have patients come to me and they are very fatalistic and they're like, well, I'm gonna have a heart attack. Like and I can't do anything about it and I can't take a medication about it. So you definitely want to make sure that if you are going to order something like this, you do know what to do about it. And right now the state of affairs is really helping them get super aggressive about everything else. And that does give them back a sense of power, right? Okay, your LDL is currently 130. I wanted this, right? This is what we're going to do to get that down. We might not be able to do something about the Lp(a), but we can absolutely change your trajectory.
Yeah, and I think that what you mentioned right there is a really important point that needs to be, I just want to underline a little bit further. I think that, with the cost, the harm of, unnecessary costs aside, the harm that it might increase anxiety in a patient. And, Dr. Beth Frades came out a long time when we talked about her initial passion about what stress does to the cardiovascular system. And I think, we don't want to order tests. And if you're not going to be able to do something about it, and if the patient's not going to receive that well, that, hey, I can maybe take care of all these other boxes, that might end up doing more harm than good. So that we got to be cognizant of that fact as well.
Absolutely.
Yeah, Dr. Harkin, I wanted to take a step back to Lp(a). You talked about how our genes really influence this, and some of our audience might be thinking, well, I wonder if I have the genetics for that, right? Can you tell us which populations typically might have high Lp(a), worse cholesterol panels, et cetera?
That's a great question. I actually don't know the exact distribution in terms of which, ethnicities are more likely to have it or anything like that. As I think it is known some populations, but as far as I'm aware, I don't think that you'd be able to reliably say, oh, well, you're XYZ,
Gotcha.
So it's super unlikely, don't worry about it. I think that, as I said, with the European guidelines, they do think that it's, quite reasonable to screen one time in everyone. And again, keeping in mind some of the considerations that we've mentioned, it's very reasonable to check at some point, as long as whoever is going to be checking it has a game plan forward about what to do about it.
Gotcha. And I just want to clarify, this test is separate from the APO-B, correct? And the advanced lipid panel for listeners?
Right.
Okay.
So Quest, there is an advanced lipid panel. So Quest has several advanced lipid panels. They do have one advanced lipid panel that also has Lp(a) in it. LabCorp, it's a separate test. In Quest, there's one bundle that does include it, and then there's another one that doesn't. So it's highly confusing. So for your average person who's probably trying to order these, but it's something that if you wanted to get drawn and you felt comfortable understanding like what the implications are going to be, you could certainly talk to your primary care doctor and say, hey, I'm concerned about this. I'd like to get it drawn. I mean, I definitely think that the people who should consider getting it is definitely anyone who has premature coronary artery disease. I think that's a given. And then certainly in any of my patients who have a family history of premature coronary artery disease, that's definitely something that I think should be checked, because it's a common cause of familial premature CAD. So those are, I think, your average person, do they need to get it drawn? I don't know that we're definitely there yet. Certainly our guidelines don't support that. But I think in people who have some of these family histories, or that they themselves do, I think it's certainly warranted.
Awesome. So we've spent a lot of time kind of defining and talking about blood markers that might give us some insight into cardiovascular health, right? What are other tests, some objective measures, such as imaging and that kind of stuff, that you might pull out of your toolbox to give us some insight on how somebody's heart's functioning?
Yeah.
Or their risk?
Right. So I think probably one of the best tools that we have right now that I think bears at least a couple minutes of conversation on is the CAC score, the coronary artery calcification score. For any listeners who don't know what that is, it's basically a specialized CAT scan that takes pictures specifically of and focuses on the heart, specifically the coronary arteries, measures and quantifies the amount of calcium contained within the coronary arteries. Many of us kind of refer to it as the colonoscopy of the heart, in that it's seen very much as a preventive tool. It is not to be used necessarily when people are having chest pain. It's more to look at disease with a preventive lens. It's sort of widely thought to be picking up, quote unquote, early stages of heart disease. That's a little bit of a misnomer because calcified plaque is by definition old plaque. It is not new plaque. So really you're picking up old disease. But regardless, it is a great tool that we have at our disposal now. And so essentially how many of us use it is when you're trying to sort of further fine tune and assess someone's risk. And it can give you a really good view into what's happening with someone's coronary arteries. Some of the examples that, and in our guidelines, it's very much acknowledged as a great tool that we can use to try to help risk stratify people, particularly in those individuals who fall at, like, say, a borderline risk, like that 5 to 7.5% 10-year cardiovascular risk. Do we start statins? Do we not start statins? Or if a patient is sort of on the fence, if they want to start them, it can be really helpful to sort of see where they're at. So, there's a lot of great, robust data that we have at this point that it can really be value added in terms of risk stratification, specifically if a coronary artery score is 0 in the right patient. That can be helpful to help us say, okay, so far so good. Let's keep watching if someone is truly opposed to statin therapy.
Yeah, I think an analogy that really helped me, and I'm still in this from Peter Attia. I hope I'll paraphrase, because I remember him talking about how, a CAC will show you something after the damage is already done, right? Like, for instance, if I did my training in Baltimore, and if you go to a place and you go to a home and you see jail bars on the windows, then you live in a bad neighborhood, right? I mean, that's kind of preventative. But a CAC, seeing a fleck of calcium or a CAC score on a young person, it's like somebody's already broken in and there's glass shattered in the back door. The damage is already done, right? And it's not, so in a 30-year-old, if you have some calcium there, then at that point, like, the red flag, the alarm bells are ringing, like, something is going on, right? That's an indicative of advanced cardiovascular disease at that point. Is that fair to say?
Yeah. So, and that's what I meant in terms of a CAC score of 0 in the right patient, right? So, it certainly is. So not only does the CAC score give you an absolute number, so it gives you, you're a 0 or you're a 10 or you're a 400, which means, and that's what I was talking about earlier with the lines blending between primary versus secondary prevention, because at that point you're secondary prevention. So it gives you that exact, that number, that absolute number, but then it also gives you a percentile. And it sort of tells you kind of relative to other people, your same age group and gender, this is kind of where you fall. And so, the CAC score is great, but it has to be used in the right context. And that's why I think it's really important to distinguish that this is not, the very earliest stages of coronary artery disease. To your point, this is healed up old plaque that has been there for some time. If you're seeing that in a 30-year-old, that's like, really, we need to get on this now. That is very highly concerning to me. and also by that nature, you have to be careful in interpreting a coronary artery calcium score of 0 in a 30-year-old, because it should be 30. It better be 30, right? And so just because it's 30 doesn't, or just because it's 0 in a 30-year-old, sure, I'm like, okay, this is good. You don't have any CAC right now, but it doesn't rule out soft plaque, right? Which is what I would expect that we would have in a 30-year-old. And so where the coronary artery calcification score is typically most useful is traditionally been used kind of 40 and above, and in super specific scenarios where you're trying to kind of figure out adding therapy or not.
So I want to switch to, because we talked about statins quite a bit, and I think that we have tremendous data to support their role, in all kinds of prevention, and you've touched on those quite a bit, or at least you mentioned it quite a bit. But I'm wondering, before we do that, is it worth talking about high sensitivity CRP? Because I've heard you talk about that quite a few times, and I know you use it in your practice.
I do. Yeah, I think we can definitely, that's definitely something I also tend to look at. And I think is, again, something that is recognized within the guidelines as a risk modifying sort of thing that you can kind of take a peek at and help you kind of make decisions. And so certainly we know, as we mentioned, cholesterol and elevated lipoproteins are a necessary in order to create atherosclerosis, but inflammation is also critically important as well, because that damages the endothelium and makes it more likely that we'll see that happen. And so we see certainly so obesity is an inflammatory disorder. So we see that in that population. We also definitely see it in kind of the autoimmune population. So we now know that individuals with lupus and psoriasis and rheumatoid arthritis are at much higher risk of cardiovascular disease, likely because of this underlying low-grade inflammation. We also see it in HIV and AIDS. So now individuals who are surviving and living long lives because of the amazing medications that we have, they tend to have very premature and really just definitely a lot of atherosclerosis, likely because of that inflammation. And so those are kind of examples of people that have known inflammatory disorders that we definitely see that association with. But it becomes just as kind of important in sort of the average person who has maybe metabolic syndrome or kind of earliest stages of that, or really early insulin resistance or something like that. So Hs-CRP can be something that we can measure to get a sense of what is that inflammatory state. It's associated with an increase, an elevated Hs-CRP above 2 is associated with an increased risk of cardiovascular disease. Rader's done those studies of, that residual risk, right? So even when we treat people with statins, we still see this inflammatory residual risk. Even though statins do, help have in terms of pleiotropic effects, they do reduce inflammation. I think, that's that next big area of research is how can we modify inflammation in a way that we reduce risk of cardiovascular disease, but also don't impair our ability to fight off infection. And so we're still obviously that's still kind of in process, but it's certainly something that we can look at. And in terms of what to do about it, definitely we do have some data to show that eating whole food plant-based diets can help lower inflammatory markers, along with lots of other helpful lifestyle changes, which I think we'll get into, I assume, on the next episode. But right. So that's one of the things I do look at, because that's something that we can definitely work on.
Well, I don't think this podcast episode can be complete unless we talk about statins, right? I mean, I think it is one of the most ubiquitous drugs we see, especially Altabash and I in the rehab world, right? I can't name one patient that comes through our rehab doors that hasn't been put on a statin. And I'm sure our audience have heard of statins, probably have, if they're younger, have parents or grandparents who might have been on it. But just from a basic standpoint, what are statins? What do they do? Why do we use them?
Okay, that's a big task in and of itself.
That might be a 3-hour topic. So
okay, so give me William a couple more minutes. Statins are a class of medications. Okay. So they, super high level, they essentially block an enzyme within the liver that is necessary to synthesize cholesterol. And so actually the mechanism by which they lower our blood levels of cholesterol is actually because what that does is it makes the liver upregulate the LDL receptors on its surface. So then it pulls more LDL cholesterol from our bloodstream. So that's kind of super basic how statins work. And as you said, they are kind of the bedrock of preventive cardiology practices all over the globe. They are a class of medications that have been around for quite some time. They were absolute game changers in terms of our ability to lower cardiovascular risk. We now have decades and decades and decades of really sound, robust data demonstrating that particularly in secondary prevention, we reduce the risk of cardiovascular events, and by as we said, mostly by that LDL lowering effect. But also well recognized are sort of these pleiotropic effects, which are poorly understood, but definitely we see some anti-inflammatory effects and things like that. Because certainly we see that in trials where we look at initiating statins the day someone has an MI, when they get wheeled into the cath lab, they get their aspirin, and they get their stent, and they get their statin, and they get their high dose statin. And so we know, and we know that even within those first 30 days post-MI, people that get that high-dose statin early on do better. So there's clearly some other effects other than just that lowering of LDL cholesterol. So they are widely used, widely studied, definitely save lives. I'd be remiss if I did not mention that they do have some side effects, certainly, and some real ones. So probably, the most commonly complained about side effects are the myalgias, the muscle aches, things like that. Some of those are dose response. Some of those are sort of the effects. And there actually was a really interesting recent study, which I'm sure you guys saw, where they looked at that really they took so the sort of the nocebo, I can never say that word.
Nocebo.
Thank you. I say placebo just fine. I don't know why. It does not go together for me. The nocebo effect. There, I said it. So there's definitely been some studies where they have looked at giving patients placebos, and it turns out that we all just have muscle aches, right? Particularly as we get older, and you guys know, like everyone has aches and pains. So ways that clinicians can sort of so anytime before I start a statin, I definitely start at a lower dose possible and work my way up. And then I also actually have patients do a muscle aches and pains notation. So I tell them to pay right now, pay attention to your body over the next day or two. What are the aches and pains you get? Write them down, because this is not the statin. And then when we start the statin next week, if you still have those aches and pains, that's not the statin, right? And so actually having people kind of take a catalog of those muscle pains can be really helpful. And I found that I get a lot less people complaining about those side effects. That said, I have had patients who have had true debilitating myalgias because of statins. And so that can be a really limiting kind of side effect. The other one that I do monitor and probably concerns me the most is just the diabetes risk. And it's there. And so we do have to just kind of be cautious and careful and monitor closely for worsening insulin resistance and diabetes.
I'm really glad that you brought that up. I think the study that you're talking about was published in BMJ 2020. I came across this one as well, but I think it's worth briefly mentioning. Basically, they took statin intolerant patients, right? And they put them into, they either gave them a placebo or a statin, and they repeated that 3 times, they repeated that 3 times, and there were 6 periods overall in random order, and the patients either got statin or placebo, and afterwards they were queried, and the patients weren't able to tell like when they were getting a statin versus a placebo, right? So they were able to show that, hey, it's not necessarily a statins. That being said, though, there are physicians who will argue that, these adverse events or effects, I should say, are much lower in randomized control trials than they are in clinical practice, right? Because again, the population for RCTs is much smaller than the amount of people in clinical practice that are seen, that are taking statins. And, prior to just over the last couple of years, as I've looked at some of the literature, again, clinically or anecdotally, I should say, I do have a lot of patients in sports medicine and rehab who tend to be maybe a little bit more active, who will say, hey, listen, like, I don't like it. I don't like how it makes it feel. Mm-hmm. Again, we can argue it might be nocebo, but at the same time, there are some statins that are more likely to cause that. I mean, so maybe a case study here would be good, right? So let's say you get a young individual who's highly active, maybe borderline athlete, who comes to you and you want to start this because it seems to be appropriate. Is there one that you might reach for initially, considering that myalgias might be something, or, that kind of stuff?
No. So I typically use if I'm using a statin because I want a desired effect, I typically reach for, and I see a very specific patient population that typically needs a lot of LDL lowering. So I am typically starting with kind of the big guns, if you will. So I usually am using rosuvastatin, low dose, but that's typically what I'm doing. I think it's easier because you never know who will have a problem and who won't. So I think personally, I start with what I would prefer to use. And then if that doesn't work, you change your game plan. So as I said, and then there's other strategies, you can go to every other day dosing. You can move to a different statin. So Prava, Pitava, if you need to kind of go to a different statin, you can do that. That's lower potency. Or, instead of up titrating, you say, Rasuva at 5 was fine, but 10 it's not, go back down to 5 and add Zetia, or go to every other day dosing and then try to work your way up. So there's different ways that you can kind of modify your dosing schedule as you need to, if someone has side effects. But I'd prefer to start with what I want to use first.
Absolutely. Well, Dr. Harkin, I want to be respectful of your time. I know a lot of the topics we just talked about today will probably come up again in part 2. And I'm excited for part 2 because we're going to be talking more about lifestyle modification, the way you practice, kind of your day-to-day and what you do with patients. So definitely excited for that. But before we let you go, tell our listeners where they can find you.
Yeah, so I am typically most active on Instagram, so Nicole Harkin, MD. And then I also have a website, Whole Heart Cardiology, all one word, .com, and they can sign up for my newsletter. If people are interested in becoming a patient, I'm licensed in New York, California, and Florida, so I see patients via telemedicine in those 3 states. I think those are the main ways to get a hold of me and see me.
Yeah, gotcha. Well, awesome. Thanks so much. Excited for part 2.
Thanks, Dr. Harkin.
Sounds great. Thanks so much.
All right. Hello, everyone. Welcome back to another episode of Medicine Redefined. This one is a part 2 with Dr. Nicole Harkin. So I'm going to say this right off the bat. If you haven't listened to part 1, highly recommend listening to that first, getting the fundamentals down in regards to cardiovascular disease, lipidology. And then this episode, we're going to be touching on kind of high-level interventions, right? Especially from a lifestyle focus, nutrition, sleep, etc. So welcome back, Dr. Harkin.
Thank you guys so much for having me on again. I'm excited to be here for part 2.
Yeah, absolutely, as we are. So let's get right into it. We want to focus this talk mainly on your approach to patients and kind of, when a new patient comes in, when you're looking at it not only from a pharmacological perspective, but also an intervention perspective that, we obviously know exercise, sleep, all these things matter. Take us through, I guess, just general overview for now. When a new patient comes into your office, what's your approach?
Yeah, so it really depends on the patient. I have a very tailored and personalized approach depending on who the patient is. Is this primary prevention? Is it secondary prevention? What are their risk factors? What testing have they already had done? What further information do we need to really determine sort of their overall cardiovascular risk and then figure out how to optimize it? Are they eating a standard American diet right now? Are they whole food, plant-based, no salt, no oil, no sugar? Where are they on that spectrum? And so every patient obviously is different. And I think that's really important, and what sets preventive cardiology clinic approach apart from sort of other kind of standard visits, which just aren't as well equipped to really go in depth and analyze these approaches. And so we know from data that the average patient seeing the average cardiologist gets no more than 3 minutes of lifestyle modification advice. And typically that ends up being eat healthier, right? And we know that doesn't work. And so really looking at a patient as an individual, figure out what are their goals, what are their barriers to change, and where do we need to go from there. So in terms of a high level approach, I typically have my patients fill out a pretty in-depth intake form prior to seeing me. I also like them to upload any prior testing, both diagnostic as well as laboratory, in advance of the appointment, so that we can really hit the ground running. And I also include on that form, what are your goals? Like, what do you identify as your major risk factors, and what are you hoping to achieve? And then just as, going through a typical visit in terms of their personal history, their family history, their medications, their supplements, all the things that we're used to sort of really getting into. But then I also do a pretty in-depth lifestyle intake. So I do ask them a lot about nutrition, not only what's a standard sort of breakfast, lunch, dinner, snack situation for them, but also how often are they consuming red meat, unprocessed red meat, packaged foods, things like that, to get a really good understanding of sort of where they're at. I also ask about sleep, both quantity and quality. I ask about stress levels, sort of rating them on a scale, and then exercise, obviously, as well, what they're currently doing. And then we go through together the current tests that they have done, and then decide sort of what other further testing might help us fine tune what their risk is. And I think we talked about this in part one, some of the typical tests that I typically look for and order, again, depending on the patient and where that's appropriate. And then we circle back and we look at everything together and then really figure out what is their biggest risk factor that we need to really work on and modify, and what's our approach going to be. As in line with our guidelines, more often than not, it is a lifestyle first approach. So how can we make changes, make tweaks to your diet, your exercise program, what have you, to achieve our goals? And then we reevaluate. And then if pharmacologic therapy proves itself to be necessary, then we talk about that at that point.
Yeah. I mean, the word that comes to mind is comprehensive, right? I mean, you talked about just even prior to seeing the patient and how much data that you're looking at. And we spend a lot of time, as you mentioned, talking about diagnostics, particularly lab markers. But I really love the fact that you talked about, hey, what are your goals? What are you hoping to get out of this? I think that's so important to highlight right at the beginning. And then I think that this concept of therapeutic alliance that Dan Pope came a long time ago talked about, although he was referring to it from, musculoskeletal rehab standpoint, but I think that applies here as well. I think that if you can identify the patient's goals, you're much more likely to have that relationship therapeutic alliance. So I really, appreciate that. Thank you. I think that, when we're focusing on lifestyle medicine, right? Some of the things that we've talked about offline is when we look at it, depending on who you're talking to, the pillars are, sleep, exercise, distress tolerance or stress tolerance. You're looking at nutrition, right? Am I missing anything else, or is there any other bucket that you look at it? from that
Those are
perspective?
the
Or
big ones. Lifestyle medicine also specifically delineates substances such as alcohol
right,
and tobacco separately, as well. And then community support, love, that sort of
awesome.
thing as well, would be kind of the last pillar.
So I have a framework in my mind of how like I like to approach it when I'm looking at it from cardiovascular health. But wherever you want to start, which one do you think out of those is kind of the bedrock, if there is even one, or wherever you'd like to start, we can go down that pathway first.
Ooh, the bedrock, I like that. I would have to say that in terms of, levers that we can pull that truly impact in oftentimes dramatic ways, nutrition is really king, I think, in terms of how can we make major changes that can either lower our blood pressure or lower our cholesterol or all of the above.
Awesome. So let's start there. And it's
Why
interesting that
not?
you picked that one. I mean, right off the bat, we're going to pick the most polarizing topic. I love it. All right, this is going to be the biggest one to tackle, but I appreciate that. I think that, you know, again, I get it, the sense every single time we have the conversation that again, it's talking to the patient and really assessing where they are, what kind of diet you just mentioned, right? Are you taking a lot of meat? You know, what's your current diet like, and then we can help you get to your goal. So this is a highly contested, highly debated topic, right? Different, is red meat, as you mentioned, is that bad for you? Red meat and cancer, you hear about that. And then, every single study comes out, whether or not it's a good study is a different discussion, but it's all over the media and people in different camps, low carb, high carb, low fat, high fat, keto, fasting, all the kind of stuff. They'll take that study and they'll say, well, this is what's really, really good for you. The way that I always think about it is, well, it depends which lens you're looking at it from, right? For instance, let's just take um, the discussion of, okay, well, so in my world of fitness and sports medicine and where I'm treating a lot of athletes, right? Let's if you're taking a physique competitor and they need to hit a goal of protein intake, right? So can you be an all plant or a vegan diet and be a high level physique competitor? Sure, you can. But we have to appreciate that it's going to have some challenges, right? Should you, right? And so for our lens, from a cardiovascular perspective, what is your overall philosophy when you're looking at nutrition, when you're having that conversation? I know it varies individual to individual, but do you have one?
Yeah, I think that from an abundance of data, both randomized controlled trials, epidemiologic data, short contained feeding trials, and as is reflective of the ACC/AHA guidelines, we know that ideally our diet should be composed of as much vegetables, fruits, whole grains, legumes, nuts, and seeds as possible. And how, in what context, and with what other things, those are sort of the margins at which we debate about those things. But I think that, and it's interesting you mentioned from the offset that this is the area where we see the most is the most highly contentious. And it's interesting because it is and it isn't, right? Like if you listen to the media and these different fringe camps about diet, I think it does end up getting really confusing really quick for the average person. But I think if you bring together sort of nutritional experts across the globe, there's actually a lot more commonality when it comes to these diets than you would otherwise think. So sure, maybe they argue over, the relative component of starchy versus non-starchy vegetables, but I don't think anyone is saying that vegetables in general are bad. I think most nutritional camps would agree that that processed and packaged foods and sugar is not good for you. So I think there actually is, if you actually line up sort of a healthful plant-based diet, a healthful Mediterranean diet, a healthful low-carb diet, you actually see a lot of commonalities. And then, sure, we can definitely talk about sort of the differences afterwards. But when you look at from a healthful cardiovascular perspective, I think the ACC/AHA guidelines did a pretty good job of sort of delineating what is known, what is not known, and what should we really emphasize. And again, then it gets back to sort of what are the patient's goals, where are they at right now, and where do they want to go. But in general, moving patients towards eating more whole unprocessed foods is definitely supported by the data.
So Dr. Harkin, one of the touted diets out there that has been at least shown, I put quotes on this, to reverse heart disease is the Dean Ornish diet, right? Which I believe he created in the 70s. And I think I'm getting this right. The Dean Ornish diet is, at least it's low fat, I think is like the main thing. And then it's whole food plant-based. But to me, I find it interesting, at least, that created in the 70s, that's around the time where we thought fat was terrible for you. And, we've since changed our minds since then. But one, what are your thoughts on that diet, right? I think that word reverse there is pretty key. We talk about reversing or stabilizing heart disease. So what if patients come up to you and they ask you about this diet, or they've tried this before, what's your take, at least, on the Ornish diet?
Yeah, so the Ornish diet is, as you said, it's actually a vegetarian diet, so it doesn't allow low-fat dairy in it, and it was created by Dean Ornish, as you said, and it was also importantly part of a comprehensive lifestyle program. So in his studies, it did incorporate moderate exercise, stress management, social support, and all of these other things. And importantly, they were pretty small trials, but they were randomized, and they did show improvements in, as I recall, exercise tolerance and reduction in angina, reduction in needs of medications, and things like that. So I think, as with any sort of smaller trials, they're very provocative and hypothesis generating. But I think in terms of disease reversal, we have to be very cautious with how we say that. And and I think when patients ask me about that, my response is, most modern cardiology trials, what we're looking at is not, most of them are not repeating angiograms and looking at plaque burden, right? That is not a typical endpoint for a cardiology trial. Most cardiology trials, we're looking at MACE, right? So we want heart outcomes, revascularization, heart attack, cardiac death, big heart outcomes. And ultimately, that's what matters to patients, right? They don't care if their plaque went from 30% to 20%. Now, if their angina went away, that's really important, right? If they don't have a heart attack, that's really important. So I think that we have to be careful in terms of, does plaque go away? Maybe, but in general, that's not likely the largest. Maybe partially that's happening. And take statins, for instance. Statins do likely reduce plaque in studies. We now know that there's definitely plaque burden that gets reduced, but that's very unlikely to be the major mechanism, at least at first, by which they're reducing cardiovascular endpoints, right? We know that statins early on, as soon as someone has an MI, you give that and they have better outcomes in 30 days. That's not plaque regression, right? That's endothelial dysfunction changing, that's inflammation, that's all the other things that happen. So I think it's a really interesting conversation, but I think that ultimately it's not really what matters. And so I think I prefer with patients to really focus more on, how can we make you feel better and live longer? If your plaque goes down by 10%, great.
I like it. Yeah, that's a good point.
Awesome. So, you mentioned that there isn't anybody who would say that plants are bad for you. I would argue there are some very
there's the carnivore crowd. That's true.
Right. And so and they would argue that some of the the toxicity in plants and whatnot. And I don't think that we're going to visit that aspect of this conversation. But if I'm not mistaken, are you plant predominant, or are you vegetarian only at this point, or for your personal diet?
I'm plant-based. So
Okay.
I was vegetarian. I became vegetarian a little over a decade ago now, and then plant-based within the last couple of years.
Gotcha. So for those who don't know the differences, what does plant-based versus vegetarian mean?
Yeah, so plant-based has variable definitions, but for the most part, it's defined as either plant exclusive or plant predominant, and specifically distinguishing from, say, vegan or vegetarian diets is defined not only by limiting or completely eliminating animal products, but specifically focuses on consuming whole food products. So as much as possible, whole foods in their whole form without being as processed. And so the foods can be, minimally processed, bread, for instance, or even, something like tofu, but ideally not processed. So this distinguishing it from, say, a vegan diet, which can and often may include highly processed foods like French fries and Oreos, that would not be inclusive of a whole food plant-based diet.
Awesome. So, and to your earlier point, I would point the listeners to John Berardi's podcast. I think one of the very first series that came out, the thing was called Diet Debates. Very interesting, where it's a 3-part series, and they're looking at, and to your point, his podcast was all about finding the common ground between different points of view. And it's actually quite interesting that when you really sift out the people who have the loudest not platform, but just the message on either ends of the spectrum, most people kind of fall in that camp. And so I think that was pretty interesting. But you talked about a little bit about the mechanism statins, right? Or you touched on briefly. And I think no discussion can be complete, science-based discussion, without talking about mechanisms. So I think the standard American diet, which is heavy on meat consumption and processed foods and whatnot, and very little on plants. And most folks agree, who are in that middle ground, that we need to increase our plant intake, as you've already said. Mechanistically, what's so good that is beneficial for our heart health?
Yeah, so plants are, and when we say plants, again, we're talking about vegetables, fruits, whole grains, legumes, nuts, seeds, potentially plant oils as well. So in general, we know that that plants are high in things like fiber, things like potassium and magnesium, polyphenols, typically in the heart healthy fats such as poly and monounsaturated fat, and they tend to be very low in cholesterol and saturated fat and sodium and things like that. And so we can go through sort of different mechanisms by which all of these things are helpful to our bodies, but essentially, we know from sort of long-term epidemiologic, both prospective and retrospective studies, looking at large populations, and whether you're taking omnivorous populations and looking at, say, Haynes data, or if you look at specifically sort of plant-based communities like the Adventists, Epic Oxford, things like that. Regardless of sort of where you fall on the spectrum, in general, we see that the more plants you consume, the lower the risk of heart disease. Now, obviously, there's lots of limitations to epidemiologic data, but it's patterns that we're looking for, right? And when you see it time and time again, you see it in people who eat exclusively plants or who eat some plants. I think that it becomes very helpful, and it definitely can inform us. So that's sort of a lot of the big data that we have in terms of heart health outcomes. And then we can also break it down into sort of the risk factors, right? And that's where we get more of the randomized controlled trials and the feeding trials and things like that. And so we know that eating plant-based diets, like for instance, say the portfolio diet, that's a specific plant-based diet that's very helpful. And we do have randomized controlled data that shows that it can lower LDL cholesterol significantly. And so we can look at different plant-based diets in terms of how they can lower cholesterol, blood pressure, body weight, inflammation, and all these other risk factors. And so taken together, that's sort of how we understand how the impact that plant-based diets can have on our heart health.
Yeah, I find the various mechanisms to be quite interesting, and it obviously would be several hours here if we try to explore every single one of them. But a study that I read actually recently, or just kind of screened the abstract when I was thinking about our discussion later today, was at least the lens of looking at the gut microbiome. And we had Dr. Will Bolsowitz come on, and we had a 2-part series with him talking about all the different aspects of how the short-chain fatty acids and feeding our gut microbiota can really help augment cardiovascular disease, and a bunch of these markers that we've touched on in the first episode. So I think that's also something that's cool. Still relatively new. I think mainstream. I think the gastroenterologist will tell you that they've been having these conversations for a long time. Darsh is fascinated with GI system, so I'm sure that he's well familiar with this. Now, the other thing, talking about the SAD diet, right? Most of us are practicing in America as we're recording this in March, and here, on, or at least when the patients come to you, right, and they'll say, well, what, Dr. Harkin, that all sounds dandy, but 4th of July comes around and I need my hot dog, and I like the hamburger, and I like all that kind of stuff. And just like plants can be challenging, I mean, meat, it's delicious, and they're not ready to give that up. Obviously, you strike me as a person who doesn't get the patient to, just completely switch, and you're working with the patient, as you mentioned several times. How do you work with them with that, right? Well, we're not going to completely abandon meat because it's not end all be all, but let's make it safer. Let's make it better.
Yeah, absolutely. So exactly as you said, I think it's all about really meeting the patient where they're at and figuring out what's the low-hanging fruit and where can we make important but impactful changes that feel doable to the patient, right? And it has to be sustainable. So if a patient comes to you and says, I cherish my hamburger once a week and there's no way I'm giving that up, then they're in that pre-contemplative stage, right? They're not making that change. And so let's talk about other things, or how can we mix it up maybe and see if they're open to that. So I think it's all about creating those, and I think we talked about the SMART goals last time, but really, specific, measurable, achievable, and time-based changes that are specific to the patient and what they want to do. And so I think goal number 1 is creating those goals together, because if they have sort of input into what changes they're making first, they are more likely to adhere to those, and then figuring out where to go from there. So oftentimes I try to focus on what can we add into the diet, first and foremost. So if they're not eating hardly any fruits and vegetables, we go through, okay, how can we get some more in, right? So maybe it's the snack, or maybe it's the lunch, or how can we tweak things so that we can get them in? And what are the barriers currently? Is that you don't like them, or you think you don't like them? Let's explore which ones you do like. Or maybe they just aren't used to cooking them. And so maybe they want to subscribe to any of these millions of services now that you can get healthy food delivered to you. So brainstorming ways where they can kind of figure out how to make some of these easier changes can be really helpful.
Yeah, the subtraction by addition method is something that I've come to be a fan of, particularly, big shout out to E.C. Sinkowski, a previous guest. And she talks about her 800 gram challenge, right? When you're eating 800 grams of plants and vegetables and fruits and whatnot, just because of the volume, you don't have room left for a lot of the other quote unquote crap. And so I'm a fan of that now, especially. No conversation on nutrition is complete without talking about supplementation. Of course, right? I mean, that's where people want to start with, unfortunately, and it's not the base of the pyramid. And I hear about this on a daily basis. I think Darsh does as well, and I'm sure you do. So, in that realm, again, I want to highlight supplements are supplemental, hence the name. But understanding that, are there some that have merit when it comes to cardiovascular health, from your perspective?
So at this point, there's not that many supplements that really do have much benefit, unfortunately. And from a cardiovascular perspective, most of the supplements that we have been enthusiastic about in the cardiovascular community have not typically panned out when they've been studied in randomized controlled trials. And so, antioxidants have been studied, vitamin C, vitamin E, I mean, you name it, it hasn't particularly panned out. So there are not that many supplements that I routinely recommend for my patients. I do tend to discuss in exclusive plant eaters, vitamin B12 is important to supplement. And so I do have my patients supplement with that. The omegas are going to be a somewhat controversial topic as well, and that could be an entire podcast on itself. But a meta-analysis that Cochrane did and others have done, that really isn't showing a major benefit of omega-3 supplementation for the average individual for cardiovascular risk reduction. Obviously, the population that has shown benefit is high dose 4 grams of EPA in individuals with cardiovascular disease who have triglycerides above 150 milligrams. And so that's sort of the one population in which we have seen benefit in an RCT. And so that's sort of the one population. I do think there is some debate within the plant-based community whether or not individuals who are exclusive plant-based may benefit from supplementation with omega-3s simply because they aren't consuming fish. We just don't have a trial that supports that really. So that's an area, a big gray area. So I think it's not wrong to supplement in that case as well. And sometimes, we'll look, and because you can't get, so you can in plants quickly, you can get omega-3s, but they're the short chain. And so algae oil actually is a way that you can supplement and get the long chain. And so many are doing that as well. But again, it's definitely a gray area there. Vitamin D is another one that both omnivores and plant-based individuals are often deficient in. And as I'm sure most of your listeners know, that's a sun exposure. When we get through sun exposure, and most of us are wearing sunscreen or inside, so many of us are deficient. So that is another one, like 1,000 IU a day that I have most of my patients take. But in terms of taking something to actually lower cardiovascular risk, we really, there isn't a lot out there that is helpful. I think that fiber is one where I do look at that closely with my patients, particularly if we're trying to lower cholesterol. If they're not able to hit sort of their soluble fiber targets, we will add sometimes like a psyllium husk or something like that to help get that lower, simply for LDL cholesterol lowering effects. And plant stanol are another supplement that I will sometimes use with my patients, again, for LDL lowering effects.
I love it. Dr. Harkin, I think you have a crystal ball in front of you because you're answering everything we're like about to ask. And we're like, oh, there it is. She's got it. So awesome. No, that was a perfect review. I was going to say, as far as omega-3s, yeah, that's what I do. I do an algae oil because like you said, I do the chia seeds, I do the flax seeds, but with that ALA conversion, and I actually tested my omega-3, like doing a quant test last year, and I was actually on the lower end. So I actually got to retest. It's been a year now. But quickly, do you ever test omega-3 or like omega-6s with your patient population, or do you not really think that ratio matters too much when trying to make change?
Great question. And I think this is another area where there is some controversy. Certainly, I think as with many things in nutrition, it's much more complicated than anyone understands right now is the answer. And I don't think anyone truly knows. I do check. I think the omega check is interesting. Again, I don't think that it is the end all be all, but I will take a peek at omega-3 levels, as you said, and that's one of the areas, understanding that it is total gray area, where if it is low, I will potentially, discuss that with omega-3 supplementation with my patients. And then the omega-6 to 3 ratio was very popular for a while. We have too much omega-6 in our diet from all our processed and packaged foods. It's pro-inflammatory. We need to eat more omega-3s. I think it's a balance, right? Just like anything, we do need both omega-6s and omega-3s. And I think omega-6s have definitely gotten unfairly villainized over the last decade or so. I don't know that we know definitively the answer to that, but undoubtedly it is important to lower our consumption of processed and packaged foods as much as possible. I don't think anyone knows the exact perfect ratio. Most people say around 10 to 1 is less than 10 to 1 is ideal. I don't know that we know that exact answer.
Okay. I want to ask you real quick before we jump into like another pillar here, is another supplement that a lot of people like to take with dinner time around the world, which is red wine, right? Which has been known with resveratrol, touted as an anti-aging supplement. And I know you recently wrote a blog post or an article on this. So if you could just tell us what's the scoop with red wine? Is it healthy? Is it not?
Yeah, so red wine, as much as everyone would love that it was super healthy, it's definitely again an interesting area of controversy. So. There was a period of time where red wine became very popular from a cardiovascular risk reduction standpoint when something called the French paradox was recognized, which was that the French seemed to have lower rates of cardiovascular disease than would be expected given their high intake of saturated fat from butter and such. And so it was postulated that potentially their consumption of red wine may be contributing to that. And one of the active compounds, as you mentioned, resveratrol, was thought to be potentially responsible for that. We've since studied it more and realized that the amount of resveratrol that we consume when we're having a glass of red wine is very unlikely to be an active enough amount to really be having the effect. And there was also certainly some data gathering issues with the French paradox observation in terms of an inaccurate representation of the amount of cardiovascular events that were occurring in the population. So what we do see from large epidemiologic data is that there does appear to be sort of a J-shaped relationship with alcohol in the sense that obviously those who consume large quantities of alcohol have a higher risk of mortality, but it seems that the lowest point of mortality vis-a-vis alcohol consumption is sort of at that moderate level, which is defined in the literature as 1 glass of alcohol a night for women and 2 for men. In terms of other, it's definitely, there's confounding variables there, certainly. And so we have to be very cautious how we interpret that data. And so in general, most of us don't recommend that people consume alcohol for its cardiovascular benefits, but that if they do consume alcohol, they consume it in sort of that moderate fashion as I described. Definitely what we know is very clear from the data that binge drinking, which is, having more than that, particularly kind of on the weekends, how many of us consume it, is detrimental to our health and can lead, it definitely is associated with the worst endpoints, both cardiovascular, AFib, MIs, things like that, but also other things like liver disease and such.
Awesome. So we're taking a top-down approach here, and we've addressed nutrition. Well, we haven't completely addressed it, but that's the best we're going to do today. And I'm going to give you the choice. I'd like to either go towards sleep and cardiovascular health or exercise. Which one would you like? Dealer's choice.
Dealer's choice. All right, let's go with sleep. Why not?
Awesome. All right. So sleep, we all love it. We get none of it. Everybody, the 3 of us, and of course, medical training. You've got a couple of children. I've got one, and feels like a couple because I'm a first-time parent. But we were talking about this offline, and I think now the conversation on sleep and the loss of sleep has, being an epidemic, the volume on it's higher and higher. We've talked about this with a few different guests, and when you're looking at it, particularly from cardiovascular disease, both of us read this book, Why We Sleep by Matthew Walker, very, very good book. But, there were some stats in there that were talked about, now reported to be controversial, but the role of coronary artery disease, the role of heart attacks. I remember him talking about daylight savings time and how when we spring forward, the incidence of heart attacks increases in the neighborhood of 25%. And whether or not that's attributed to the hour of sleep loss, I mean, that's up for debate. But also when you're falling back, the incidence of heart attacks on that Tuesday following the Sunday is down 21%. And that really got me thinking about this. Okay, well, what is the effect? And, I'm curious to get your take from cardiology perspective and your studying of the literature is with the correlation of MIs and sleep loss or sleep deprivation. Where do you stand on that?
Yeah, so I think that the literature is fairly clear that insufficient sleep duration, which is typically defined as less than 7 hours a night. And then also conversely, too much sleep, long sleep duration, which is usually defined as over 9 hours, is associated with increased mortality, specifically cardiovascular mortality. And, we've, again, similar to most of our lifestyle pillars, a lot of what we have is epidemiologic data like that, and then biomarkers. And so the different biomarkers that we've looked at, we've seen associations with insufficient sleep duration or poor sleep, with things like inflammation, higher levels of insulin, all these different biomarkers. I think the one that's best studied and is most provocative is blood pressure. So blood pressure has binaural variations, and it fluctuates over the day, and then is supposed to dip at nighttime. So when we're interpreting ambulatory blood pressure, this is actually, I think, one of the most useful reasons to do an ambulatory blood pressure monitor, is because you can actually look and see what someone's blood pressure does at night. And it is supposed to dip. And if they don't, and it's variably defined, but it's usually if their blood pressure does not go down, meaning dip, at least 15 to 20% overnight, then they're considered a non-dipper. And that non-dipping status is associated with increased risk of cardiovascular disease, even above and beyond just the diagnosis of daytime chronic hypertension. And so and that link between poor sleep quality and insufficient sleep duration is most closely associated with this non-dipping status. We also see it in individuals with obstructive sleep apnea and other sleep disorders. And so I think hypertension is certainly probably important in terms of it's how it increases our risk of cardiovascular disease when we're not sleeping enough or when we're not getting good enough sleep.
Yeah, so that indirect mechanism seems to make a lot of sense. I'm curious, what is your explanation, if you have one, about the prolonged sleep, greater than 9 hours or greater than 10 hours for increased mortality? Have you given some thought to that?
I mean, I think it's likely just a marker of something else. So you have some sort of chronic disease state, something that is making you sleep longer.
Right. And I think that, again, paraphrasing Dr. Walker, when he talked about, his explanation was that most of those folks maybe are dealing with some type of cancer or some type of chronic disease, as you just mentioned. And the fact of the matter is that the body or the sleep wasn't able to, quote unquote, save them. And so I think, that's, as you mentioned a couple of times now, with these observational studies and epidemiological data, it's very, very challenging. But sometimes the science is imperfect and the best that we have. An interesting paper that I read this morning, and this was published in PLOS Biology. Again, the senior author is Matthew Walker, but Peter T is on it too, Darsh, for you. I'll send it to you guys if you're interested. And they looked at one of the proposed mechanism of atherosclerosis. It was interesting because they took some of the MESA folks and the objective markers they were looking at was 7 days of actigraphy. And they were really looking at sleep fragmentation or one night of PSG data. And they documented the white blood cell count, so particularly neutrophils and monocytes, and they correlated that with CAC scores. What they found, on both instances between actigraphy and PSG data, that the neutrophil count after a night of sleep deprivation would increase. One night for PSG, but also actigraphy over 7 days. I don't understand plaque formation as well as you do, and you explained a little bit, but is that something that is plausible to you in terms of how that could cause premature heart disease or CAD in particular?
So maybe just being reflective of overall inflammation, perhaps. I'm not sure, but that's definitely interesting.
Yeah. Are there any other proposed mechanism? You talked about hypertension, right? With the confounding stuff like age, sleep apnea, that kind of stuff like that. But in terms of looking at atherosclerosis, what is your understanding of, or our understanding of, how that happens?
To my knowledge, that isn't known. I think that, as with most of sort of these lifestyle mediated issues, it's still not fully understood. I think that we have definitely demonstrated that insufficient sleep quality and quantity is associated with many of these different biomarkers, which then increases risk for cardiovascular disease. I think also similarly to something like stress, when you're super stressed or super tired, you don't make great choices, right? So then there's the indirect issues that play as well, where we don't exercise because we didn't sleep enough, or we eat, comfort foods or what have you. So I think it's likely very multifactorial, and there's both direct and indirect consequences at play.
Yeah, I'll disclose last night about making poor choices. I think it was at 11 o'clock after multiple nights of sleep deprivation. I had these peanut butter dark chocolate bars, and I had just 4 of them at 11 o'clock without even thinking about it. And this is a point of debate again in this household of why we should even have these, but I digress. Let's switch to exercise.
Hungry,
okay,
man.
My favorite one was that
I'm fasting right now. You're making me hungry. We can't have food talk.
Ours is on 24 hour.
24-hour call.
Let's switch to exercise. Now, this is definitely my favorite one. It's the one that comes easiest to me to do, and it's just part of my core identity, I think. And when I look at it, of course, to make it simple for folks, right? We're talking either aerobic or quote unquote cardiovascular exercise, right? When most people look at it, or a lot of strength training, resistance training, right? And I think those are the big general buckets. Before I ask you about that, I'm curious, what does your exercise regimen look like?
Good question. So I typically am, so it's definitely morphed over the years. And I will say that some of that is reflective of, kind of having a better understanding of the need to have both quote unquote cardio and resistance training. I think I definitely was really into running and a lot of cardio, and pretty much exclusively doing that. Right now, my balance is a little bit better, although not as consistent, which is interesting. So I typically, for cardio, a couple times a week, I am on the Peloton. And then we actually recently got a tonal. And so I have been doing more strength training. So I'm trying to do at least two to three of those during the week as well. So I have found that to be really helpful for me for someone who earlier in my life did not do much weight training at all. It's pretty plug and play and makes it pretty easy.
So why the weight training, at least, for the general public? I think many people can understand, obviously, why we do the running, aerobic training, get the heart pumping, but not many do the weightlifting. What's the proposed mechanism behind that being beneficial for heart disease?
Yeah, so I think that is also a very good question and not 100% fully understood. So, briefly for your listeners, as I'm sure most of them know, for cardiovascular disease prevention, the ACC/AHA guidelines really do focus on the aerobic activity. We're really trying to get 150 minutes of moderate intensity exercise a week, or 75 minutes of vigorous aerobic activity. And as you said, it's kind of easier to understand kind of the hemodynamic changes and all these things that, like, why that is good for us. Interestingly, the ACC/AHA doesn't specifically recommend within the guidelines to do strength training. I think their language is that should be encouraged. But unlike a lot of other, I think most of the other guidelines, I think for diabetes and for sports medicine, I think most of the other guidelines do specifically call out kind of resistance training. And that's, I think, reflective of the fact that the level of evidence we have for strength training in terms of cardiovascular prevention is not as strong. That said, I think it's definitely emerging, and it's definitely very provocative. And so I've started to really emphasize that with my patients as well, because I think most of them are getting that aerobic activity that they should be getting, and not focusing enough on the strength training. And so I think the areas in which the data is the strongest is we do have some epi data to show that individuals who do some strength training have lower risk of heart disease, but I think the data is the strongest with specific cardiovascular risk factors. So body composition being one of them. So definitely in terms of reducing visceral fat. I think the other one where we have a decent amount of data is for hypertension management, actually. So there's a handful of randomized controlled trials that show that resistance training definitely can reduce blood pressure above and beyond just what can be achieved with aerobic training alone. And then also in terms of glucose regulation and insulin resistance, we also see that its resistance training is actually better than traditional aerobic activity, and actually kind of can combine with aerobic activity to get the most reductions. And so I think when it comes to kind of looking at these different cardiovascular risk factors, those are pretty provocative and really interesting to me.
Yeah, I think the insight I'll add on to that in terms of resistance training, what I remember learning back in undergrad exercise science is, well, when you increase in the immediate post-exercise phase, when you're lifting heavy weights, and if you're doing Valsalva or something like that, you're going to increase blood pressure, right? And so when you increase that afterload, your heart has to work much harder, right? There's this concept of the athlete's heart, and we often see right ventricular hypertrophy as a response remodeling wise, but we also see sometimes left, although most of the time that's pathologic, right? You don't want that. Is that correct? Left LVH?
So we do see both. Yeah. So we see LVH, and actually we also see increased systolic volumes in resistance training athletes that typically does resolve with deconditioning. Although at this point we don't typically recommend deconditioning. So we don't necessarily consider it pathologic.
Right.
Really the main reason we would have people decondition was just to make sure that it wasn't, that it wasn't pathologic, so that it wasn't, hypertrophic cardiomyopathy or something like that.
Right. But the increased contractility that would come with the, ventricular thickness, would that not explain it in terms of kind of the overall benefit, to answer Darsh's question, in terms of the mechanisms? Because if you have ventricular hypertrophy, your contractility would increase, right?
Correct. Typically, right. I mean, it depends. So we didn't. So in terms of the athlete's heart, we don't consider it necessarily like pathologic in that it's increasing your risk of developing heart disease. If that's
gotcha.
What you're saying.
Okay. And so from, again, now quote unquote cardiovascular exercise or the aerobic training, right? My understanding is, again, so you bring more preload, right? The heart's capacity of how much it can hold before it pumps all that blood out throughout the extremities, which will down the road allow it to have a lower heart rate. So it has to pump less frequently, right? And so you can have cardiac output can remain high. Is that kind of how the conversation you're having with folks when you're explaining why aerobic exercise is beneficial, or are there something else? Like, is there something else that you're talking about?
Oh, sorry. So going back to aerobic exercise.
Yeah, right. I'm going back to it. Yep.
Yeah. So, I mean, we see all kinds of changes in terms of the things that occur within the body in response to aerobic training. So there's all of these different sort of hemodynamic changes. And then there's also, I mean, we see, increased HRV, we see, obviously decreased blood pressure. We see, increased insulin sensitivity. I mean, there's tons of different changes that occur within the body in response to aerobic training.
Awesome. Go ahead, Darsh.
Yeah. Dr. Harkin, is there a limit that you'll put your patients on in terms of running and how much aerobic exercise? I mean, I think there's data out there that suggests like a lot of marathon runners actually can develop AFib later on just by the mechanisms that we're talking about, right? Is there anything like that you kind of caution?
So I think we are increasingly realizing there is such thing as too much of a good thing. Most of the benefit, so as I said, we recommend 150 minutes of moderate intensity exercise a week. We definitely see continued benefit up until around 300 minutes a week. And then from there, definitely likely a plateau. As you said, there's definitely been some studies with, really high level athletes having actually higher levels of coronary calcium so they've done studies with high level athletes and they have higher rates of CAC. And then AFib, as you mentioned, there's been some of that as well. So I think that there is probably such thing as too much of a good thing. And I think that's another way in which some of my patients who are doing lots and lots of aerobic activity, it's a good way to sort of, let's diversify your routine a little bit and add in the resistance training, not only because there is potentially that signal of harm at very, very high levels, but also because of all of these amazing benefits from strength training as well.
I like that. Yeah. And just to mention kind of Peter Attia's model for exercise with longevity, he talks about having a solid aerobic, anaerobic, stability, and strength program. And when you kind of have all of those four aligned is where you'll kind of be the most optimized, if I can say. Awesome. So
yeah, and I think also I would just also mention that I think we're talking about sort of discrete moments of intentional activity that we're doing, but I think also what gets missed a lot is sort of all the other movement that we should be doing throughout our day, because being sedentary is really associated with some of the highest levels of mortality. And there's actually some data to show that even if you sit at your desk all day long and you do your 30 or 45 minutes of exercise, that may not even discount that sedentary activity. And so I think it's also important that yes, we get our 30 to 45 minutes in of whatever our activity is that we're choosing to do, but then also carving out moments of other moments in our day where we're not just sitting at the computer all day. So if you can take a walking meeting, or if you can take the stairs, or like all these other ways that we can increase our NEAT, I think that's also, important and bears mentioning, because it's not as sexy as the other stuff, but it's actually really important.
That's a very, very, very important point that you brought up. That I don't know how Altosh and I missed her there, but no, thank you so much for bringing that up. Then something I've been doing at least is after a meal, trying to just even do like a 2 to 5 minute walk, right? Just to get those steps in, also kind of help the sugar regulation and everything. So very good point. All right. I want to move on now to stress, right? Something that we could all use a little bit of now in a good way, but with COVID and with us being in the healthcare, I mean, stress is always at an all-time high, I feel like, for us. What is the biggest marker, at least in the cardiovascular world, that you're seeing with stress? Is it blood pressure that usually, you're seeing? Yeah.
Yeah, so definitely stress. I think that's another area within lifestyle medicine that is poorly studied, but we certainly do have data that indicates that, chronic low-grade stress is likely associated with increased risk of cardiovascular disease. Previously, the data was mostly looking at kind of acute periods of high stress, like PTSD and stuff like that. The chronic low grade is probably not so good for us either. But in terms of pathways and things like that, certainly the blood pressure association is where it's best studied. And interventions like meditation and other stress reduction techniques. While we don't have a lot of data, what we do have shows that we can reduce, blood pressure with specifically transcendental meditations, what's been studied best. But we do have some evidence that it can be helpful.
So maybe the more important question: what's your intervention when it comes to this? I think like when we talk to most folks who are maybe in this space, right? I mean, this is maybe the most challenging. Personally, for me, it's probably the most challenging. We're all in medicine. I mean, stress is ubiquitous in our daily thing. We're parents now. You talked about getting steps in. You're running after your children. That's a workout, right? I'm sure. But when your patients are coming to you and you're talking about this distress tolerance, what's your conversation like? How are you approaching that?
Yeah. So I think, first I have them, talk to me about, first I have them rate their stress. And I find that a really useful point in terms of figuring out where are they. I do have occasional patients that give me a 1 and I'm like, okay, what are your secrets? Teach me. But most people, especially right now, are pretty high. Give it, an 8 or a 9. And so that helps me frame the conversation, because you only, I do hour-long intakes, but again, you only have so much time. And so I like to know how much stress are they having, and is this something that we really should address? And so I first have them start there, and then if they are having a lot of stress, I talk to them about, or I ask them rather, where is their stress mostly coming from? Sometimes we're able to do some problem solving in terms of finding the root cause and working on trying to find ways to reduce that stress if it's one discrete thing. But more often than not, it's, again, this chronic low-grade stress from a million different sources. And so I talk to them about stress reduction strategies. And so some people are open to meditation, other people aren't. I think that it's actually quite helpful that there's so many different apps. I think there's like an app for every personality at this point for meditation. And so most people just need to hear that they should give it a try, and that there are options and you don't have to be good at it. And that I feel like I'm quote unquote not good at it. I don't think many people think they are. And that's not the point. The point is sitting and doing it. So yeah, I have people try the different apps depending on their personality. If they're not at all interested in meditation, we discuss other ways for stress reduction. It can be as simple as making sure they give their best friend a call every night, or taking a bath, giving themselves permission to take a bath and read a book or whatever. So oftentimes it's not this like groundbreaking, amazing stuff that no one's ever heard of, but it's having that conversation and having your doctor tell you this is important and you need to carve this out and let's figure out a way. And it doesn't have to be long. Like I meditate 10 minutes before bed. Ideally I have longer, but I don't right now, and that's okay. And so it's all about kind of having someone help you figure out a way to put that into your life and try to really make it a priority, and also just doing your best and not aiming for perfection.
I love that. I think meditation brings a lot of perspective, not only in the moment, but also to the rest of those lifestyle pillars, right? When you actually get the time to sit down and reflect, you start to look at everything else in your daily routine. And I think that's where you also get to see the change. So not only from the stress perspective, but also from, okay, the diet, the exercise, how do I kind of get better, right? By 1% every day. I want to touch on another method, at least that's kind of been booming now, which is in the biohacking world, which is the sauna, which I don't even think should be a biohack because, I mean, there's so many great benefits that we now know. And when I listen to other cardiologists on podcasts, I've routinely been hearing that this might be a proposed treatment in the future where we'll actually write on a script saying, go to the sauna for 20 minutes. What is your take on saunas based off like the papers you've read, and if people can even tolerate it, right? I mean, I don't think it should be probably for everyone, but you probably have to be at a baseline, somewhat of a healthy level in order to get into a sauna.
Yeah, no, I definitely have. I can think of one patient who was not in a place in his health where I recommended the sauna because I actually was concerned he was pretty unstable. But yeah, so I think sauna is really interesting. I think it, like a lot of things that we're starting to learn, is really interesting in terms of the impact that it potentially could have, simply because of how it can stress your body in a good way and get our bodies used to that. So I think it's really interesting. I think we're definitely not at that place where most of us are quite prescribing it yet. But I think the data is certainly interesting and emergent.
Awesome. Well, Dr. Harkin, as we come to a close here, I want to, of course, thank you for 2 amazing discussions. But I'd be remiss if I didn't ask you about the future of preventive cardiology. More specifically, I think that the first part of the discussion that we had, we spent a lot of time talking about areas where we're trying to understand why the current standard of care, the way we practice it, and why are we looking at specific markers like LDL particle number, APO-B, even though the European guidelines suggest that. And if somebody listens to this and they're convinced that this might be key or instrumental in their role, how can patients have a conversation with their provider for the need of these advanced testing, which may, alter their care, or they may be more informed so they can make other decisions, so they can, affect different pillars of lifestyle medicine, or whether it's pharmacological treatment, whatever that might be. This is a question I wanted to ask you last time, but I didn't get a chance to, so I'm going to ask now, is how can they have a conversation, whether it's cardiologist, primary care provider, whoever it might be?
Yeah, I think that's a really good question, because by and large, most people will not necessarily have a preventive cardiologist as a member of their care team. Although hopefully that will change. I do think that, whether it's based on risk factors or just you hit a certain age, I really would hope that everyone would be able to access at least once a preventive cardiologist to really kind of get a lot of their personalized questions answered. But that said, I think that like the American Society of Preventive Cardiology emphasizes that it's not just cardiologists that can be practicing preventive cardiology, right? It's endocrinologists, it's internists, it's sports medicine docs. It's really anyone who has an eye towards, preventing cardiovascular disease, which hopefully is all of us physicians and other members of the healthcare team, given that it is the number one killer globally. And so I think that certainly, hopefully all of us will do a better job of having these types of conversations so that more healthcare professionals are exposed to these different topics. And while it can be difficult to keep up with, every emerging piece of literature, none of us can, hopefully they're, at least exposed to some of kind of these topics that are increasingly becoming important. But in terms of kind of a patient specifically being able to access some of these things, I think it's discussing with them. I think it's really important that, say you're seeing your primary care physician for your annual physical, and, hey doc, what do you think is my cardiovascular risk? Like, have you plugged me into the ACC/AHA 10-year risk calculator, or whatever it is, maybe not that specific exact language, or they could. Why not? Have you?
After listening to this, they will.
Because I think that your average PCP has like 8 million things that they need to check and do, and so just kind of bringing that to their forefront of their mind and reminding them that this is something that's super important to them is a great way to kind of start the conversation. And maybe the doc will be like, oh yeah, your risk is pretty low for XYZ reason. And so maybe you don't need additional testing at that point, but potentially they will be like, oh, I haven't checked it, let's check and see what's your risk. Or, the next question could be, hey, do you think I would benefit from a coronary artery calcium score, or, whatever it is. And again, not everyone needs these types of tests, but at least it's, if you're interested or you think you might benefit, having those conversations. And if you feel like your provider sort of goals are not in line with yours, then finding someone who has, who is more in line with what you're looking for. Not everyone's going to be the right fit for everyone. It's not a personal thing, and that's totally fine. But I think that, starting to have those conversations in a really, just non-judgmental, non-accusatory way, but hey, I was thinking about this, or hey, I read this, what do you think? And starting that conversation.
So on the flip side, hey, I just checked ASPC. I actually didn't even know it was a thing. I'm definitely going to look into becoming a member. That's awesome.
You should.
Maybe I'll see it in Louisville, Kentucky. It looks like in July, so that's awesome. If a healthcare practitioner or somebody who has an interest, right? I mean, you mentioned last time that cardiology is very, very cool. I obviously think so as well, and I think you've made a pretty good case that it is cool in these last two discussions. If not, it is very, very important considering the burden of cardiovascular disease. And if providers want to learn more about this type of stuff, right? Some of the advanced testing, preventative cardiology, and specific. What resources could they use or to learn more about this stuff?
Yeah, absolutely. So I think that, so the ACC has CardioSmart, which is a lot of patient, but also provider resources. They have some podcast series at this point, lots of handouts that you can use for your patients. The American Society of Preventive Cardiology, I think, is another great organization that has a lot of great content that is being put out in terms of guidelines and things like that. Definitely familiarizing yourself with the ACC/AHA guidelines. There's the primary prevention guidelines, and then digging deeper, right? So read, if you're interested, reading the guidelines and then looking at the resources, looking at their sources, going into the primary literature if you have time. It's really, illuminating, and that's where you can start to kind of better understand where these guidelines are coming from.
You might have forgotten the most important one. I think wholeheartcardiology.com. Is that right?
Absolutely. So my website's Whole Heart Cardiology. And yeah, I have a blog and a newsletter and all that kind of stuff. So it's mostly geared towards patients, but I actually have a handful of my primary care docs that routinely refer to me that have subscribed and say they actually really enjoy it.
Awesome. Well, Dr. Harkin, it's also International Women's Day, so happy International Women's Day to you. In cardiology, women are definitely underrepresented, and you're just proof of that as to why we need more and the value that you create. So thank you very much for coming on here. Final question for you is, how do we add the health back in healthcare?
Great question. I think by all of us advocating together for what we need, I think that both physicians and patients are frustrated with where we're at. And so I think that the more of us on both sides of the equation that speak out, the better. Because I think that, patients just come to me time and time again, why has no one talked to me about this before? I can't believe I'm hearing this for the first time. And I truly, it is just, it's frustrating that no one's getting the care that they want. We spend so much money as a nation on our healthcare, and yet we are sicker than ever. And so we all deserve better.
Love it. Yep. Couldn't have said it better. So thank you so much again.
Thanks so much for having me.